Sorry for the inevitable technical difficulties, but there's 115 of you on, so we are slowly making our way into the room, and I see Joe Humlar is here. Angelina, do you think we can go ahead and kick things off?
Yeah, I think let's get started. And Maria and Marilyn and I will all keep an eye out for emails or people who are having a hard time getting in.
Perfect. Thank you. So Joe, we'll leave it to you to kick things off if you're ready.
Yeah, you bet. Thanks, Yumiko, and thanks, Angelina. It's great to have so many people get together for a very important learning collaborative. This is the second in a series of, help me out, four learning collaboratives as we get together and contemplate how we re-envision how we're supporting Colorado's kids and families. I want to thank Yumiko and Angelina for putting this together today. There's a lot of work to make sure that everybody's voices are heard and to make sure that your best ideas are counted and rolled into how we envision our system. Joe Humlar, Division Director for Child Welfare at CDHS, and today's conversation will be a deep dive into residential child caring facilities and qualified residential treatment providers. Those are acronyms that we have seen, all of us have seen in our emails that have been shared back and forth with one another over the past several years as we contemplate how we move forward in a family first environment that's fully supportive. There's a lot of folks on this call. Thank you very much. We have placement providers, we have service providers, we have Division of Child Welfare staff, we have folks from various state and government agencies, county departments, frontline workers. Hats off to everybody, not only for being here and part of this meeting, but for serving during this pandemic and giving your best in everything that we do. So thank you. We're here to listen to one another, and we're here to double down on Colorado's great work. Today, I'm pleased to share that, and many of us know, that we have the least amount of kids in out-of-home placement ever before in Colorado's history, despite having recent population growth in Colorado. We have more kids with kin, more kids with open services right now than ever before in Colorado's history. And specifically related to congregate care, we have the least amount of kids and youth in congregate care facilities, least amount of placements that we have ever seen in Colorado's history. That's a 66% decrease in congregate care placements from 2,185 children and youth to 724 children and youth to this day. And not only hats off to child welfare staff, to state staff, but hats off to placement providers, hats off to facilities that have been thinking differently at serving kids in different ways and being creative. And the reason why we're here today is to build the future. So our past and our present looks good. We've come a long way, and we're here to build the future. We have invested so many groups, and a large number of folks on this call have been involved in different committees, different task forces related to thinking about outcomes and incentivizing performance. And we're excited about next steps in implementing scientific and creative approaches to solutions moving forward. We want to make sure that we are having a child-centered, a client-centered approach to what we do, so that a child or youth's unique gifts and needs, that we can be responsive in the programs that we build out to be even more dynamic, responsive, and high value. We want to make sure that the work is done behind the scenes so that through the eyes of a child, their moves are minimized. The connections that they have with staff, so many of you, can be developed and doubled down on. And so that even more than before, we can create a continuum so that a young person's experience is seamless, and so that the connections they make can flow with them throughout their journey and healing. We want to make sure that we support you, the great work of our caring providers, so that all of our creative ideas that we have today are supported in investments and supported in policy. We need you. We need to have your backs as you're out there doing such great work. And we need you to know that we value very much our partnerships, and we're in this together. And we all need to hold ourselves in whatever lane of work that we see ourselves in serving we all need to be holding ourselves accountable to think differently so that we can respond to the needs of any and all Coloradans out there, whether they're in need of service because of a safety issue, because of a family crisis, or to prevent system involvement in the first place. We need to be responsive to Coloradans, and we're doing that. So we need your help and great ideas. We're going to spend our Wednesday sharing these great ideas, and we're going to embark, as we always do in Coloradans. We do this a lot. We do this together, we do this in community, and we need to do this with a solution-focused approach. Every worry that we have has an opportunity buried within. We don't want to gloss over any threats, but we do want to engage with an idealized attitude. Every opportunity is buried within a worry, and so it's our job right now to find that together and work through things. So I know and I trust that you're with us, and let's roll up our sleeves and dig in. I will be joined by a number of colleagues, I believe in the last half hour, so that's how it went last week, in some deeper dives related to the eyes of a child case studies that we're going to bring in. So I look forward to meeting the folks that I'm going to be doing more work in the second hour here, and many of the DCW folks are going to be in partnership in those calls as well. So thanks, welcome, let's get to it.
Wonderful. Thank you so much for that, Joe. My name is Yumiko Doherty. I am also with CDHS and currently acting as the Chief Strategist for Family First. And I'm going to help facilitate this meeting today with all of you. So thank you so much. It's great to see so many of you on the call, your willingness to engage with us in thinking through the future placement continuum in Colorado. So without further ado, we have a lot to get to today over the next couple hours, and this is kind of the framework that we're going to be using for today's meeting. So I'm going to start off by just laying out the vision that we have here at the state for the future placement continuum, as well as some important context for the conversations that we're going to have. Then we're going to, as Joe mentioned, really dig into this question of who are we designing the system for and what are their needs? So really grounding ourselves in a child and youth-centered design approach to today's conversations. Next, we'll have a small panel of experts sharing some real-life examples from various perspectives with the purpose of really helping to spur some ideas and innovative thinking as we head into our small breakout discussion groups. We're hoping to leave a good chunk of time, hopefully the last hour or so, to really dig in smaller group discussion, because that's where the magic's going to happen, right? That's where we're really going to be able to engage with each other across different perspectives and use individual use cases to really build out and dream big what we want the system to look like into the future. And so I really encourage you to stick with us throughout the 2 hours. It's really that second half where we're going to dig in and start being innovative together. So that's what we're going to do today. For the sake of time, again, because we do want to leave as much time as possible for discussion, we're not going to leave a lot of room in this big group for some open Q&A. If you do have questions or comments, please feel free to type them into the chat. There's a number of my colleagues on this call today that can help manage that and monitor it and try to respond to some of your questions in writing if we can't get to them through discussion today. So just know that we're monitoring that, and know that there will be plenty of time for you to get your ideas and thoughts out in those smaller group discussions later on. So starting with the vision, and of course, all of the learning collaboratives that we're standing up are very much in service of this broader vision, which really consists of 3 parts. First, we want to right-size our placement continuum to be more responsive to the needs of children and youth in care. And we are going to be hammering that point home throughout today. We want to start with a good understanding of what are the needs of our children and youth, and then work to build and design a system around those needs. Second, and this very much mirrors the values and the intentions behind Family First, we want to ensure that every child, when necessary, is either in a family-like setting or a small, high-quality, treatment-focused facility. And then finally, we want to ensure that all families have access to appropriate, responsive, and effective services at every level of the continuum. And so even though these conversations are framed around placement types or levels of placement, we necessarily have to have conversations about all the various services and supports that need to surround any level of placement to make sure that it's successful and responsive. So that's the vision. And in terms of context, this is a very interesting time. As Joe said, it can be, it's a little unsettling given all of the change and reforms happening all at once, but it's also an exciting time for us to create and really fully take advantage of all the opportunities ahead of us. And so in terms of context, and I'm sure all of you are feeling this, right? We have various major reforms that are all converging at the same time. So of course, there's the Federal Family First Prevention Services Act, which I know many of you have been involved in the many discussions, conversations, and planning efforts over the last couple of years around that law. But then also within Colorado over the last couple of years, there's been some major child welfare and juvenile justice reform that has happened. The Colorado Behavioral Health Task Force just recently wrapped up and is doing some initial implementation of its blueprint for reform. And then finally, the Institutions for Mental Diseases, or IMD issue, which isn't necessarily a reform, but it is certainly interacting with some of these various reforms to have a major impact on our current placement continuum. And so I'm going to attempt to visually show what some of these reforms, how they're impacting the current state or the current placement continuum. So here in very simplified terms is the current state, right? So when we do need to place a child or youth outside of the home, he or she either goes to a family-like setting, which is basically a non-certified or certified kinship home, or a traditional foster home. Or the child or youth goes to a congregate care setting, which basically consists of group homes, group centers, and residential child care facilities. What Family First is saying is that the federal government, through Title IV-E funding, is no longer going to financially support or reimburse certain levels of congregate care placement. And in Colorado, that translates to our group homes, group centers, and RCCFs. Instead, what Family First is really doing is incentivizing and prioritizing the lower end of the spectrum, all the way at trying to ensure we don't need to place children or youth out of the home. So there's a big emphasis on utilizing evidence-based prevention services to keep families together safely in the home. And when that's not possible, ensuring that there's enough home or family-like settings for children and youth. And when needed, there is a higher level of high-quality, short-term treatment-focused care available. And Family First created the QRTPs, Qualified Residential Treatment Programs, for that purpose. And again, this vision very much aligns with what I outlined as Colorado's vision as well. What IMD is doing in a nutshell, IMD has to do with Medicaid reimbursement. So for facilities, residential facilities that are treatment focused, so our QRTPs, ultimately IMD has the impact of placing a cap on the number of beds that those facilities can have. So if in Colorado, we want to continue accessing Medicaid for the children and youth in these facilities, QRTPs need to find a way to be 16 beds or fewer. Okay, so when we look at the system as a whole, IMD is putting downward pressure on our capacity at the higher end of our continuum. And so the main challenge with these two reforms happening simultaneously is how can we meet the needs of higher acuity children and youth? How can we meet those needs in lower levels of care or in community-based alternatives to residential treatment? And today's conversation is kind of going to straddle both of these, right? Because we want to ensure we have a robust level of QRTPs. So we want to talk about designing what does that level of care look like. But we also want to be thinking about what are some of the alternatives to QRTP level of care? What are some other ways to meet a similar level of needs in the community? So we're going to be kind of working on both of those issues simultaneously. here is a nice visual of kind of as we envision the future state of the placement continuum in Colorado. Again, we want to ensure that every level we are being responsive to the needs of children and youth, that we have robust community-based services across every level of the continuum. And then again, you'll see our vision as well as Family First reflected here, where the continuum really ranges from in-home services all the way through the more intensive treatment-focused residential settings. And as you can tell from this versus the first visual that I showed, what we're really trying to do is diversify and make this continuum much more responsive and nuanced to the various needs of children and youth. So even if we look at the family-like settings column, we're working on building out not just traditional foster homes, but also therapeutic and treatment foster homes. So again, while we're focused on QRTP level of care today, we also want to start looking at some of those other options available for kids with higher level needs. Just real quick, I wanted to mention a few relevant terms to level set for all of us going into the conversations today. QRTP, you're going to hear that quite a bit today. Again, that stands for Qualified Residential Treatment Programs. Those were created under the Family First Act and are really designed to ensure a more treatment-focused, trauma-informed environment to lead to kind of shorter lengths of stay, increased quality, and better outcomes for kids at the higher end of our placement continuum. And Family First sets a range of requirements for that level of care. For example, QRTPs need to be licensed and nationally accredited. They need to have trauma-informed treatment models and 24/7 access to clinical staff, as well as need to engage in planning and at least 6 months of post-discharge aftercare for families. So there's a whole host of requirements that go around these QRTPs. In order to place a child or youth in a QRTP, we need to conduct an independent assessment by a qualified individual to ensure that the clinical needs of that child and youth are truly appropriate for that level of care. And in Colorado, we've chosen the CANS tool, the Child and Adolescent Needs and Strengths tool, to serve as our assessment. Those last two pieces on the independent assessor and the CANS, Andrew Gabor from the Office of Behavioral Health is going to be joining us a little bit later to tease out those pieces for us and to talk a little bit about what those things mean and what they do not, and do a little bit of myth busting around those pieces for us. And then finally, to be determined, right? So in our discussions, we don't want to just talk about what does the QRTP level of care look like, but also a host of other things that children and youth may benefit from at this level in the continuum. You might be talking about things like respite or assessment, probably digging into a lot of different services and supports that are needed for children and youth. So in terms of the terms that are coming up, I'm excited to see the list of terms that we all start using and talking about in our discussions today. And then finally, the elephant in the room. Before we move on, I did want to address the elephant here, which is IMD. And I know there probably are a number of you on the call who are very familiar with IMD and the impact that it's having. Some of you may be hearing about it for the very first time. Again, IMD is impacting Medicaid reimbursement for our QRTP levels of care. And the elephant is really that we still have some outstanding questions and lack of clarity around truly how IMD regulations are going to impact our facilities, particularly those that have multiple sites or are in campus-like settings. But we unfortunately are not yet in that position. And it's not due to a lack of effort. I can assure you there are a number of folks within the Division of Child Welfare with our partners at HCPF who are very much working on this issue to get as much clarity and guidance as we can out to everybody. And it's truly a balancing act between wanting to ensure that we are aligned with the federal definitions of IMDs and we're not getting ourselves into trouble with the feds, with also wanting to be as creative and innovative as we can, sticking to the values of smaller is better, but also ensuring that we have adequate capacity and we can all move forward successfully under this new continuum. So I know that this is producing some anxiety, of course, for providers, counties, everyone. And we are working on it and hope to get more clarity around these issues very soon. And our provider services unit is standing by and will very much be ready to work one-on-one with facilities as we get more information and clarity and how that may impact you as a provider. And we will certainly communicate out to all stakeholders as soon as we have more information. All that being said, I think we absolutely can still move forward today in terms of having visionary, robust, innovative conversation about what children and youth need and how we want to respond to that and build our system, right? So even though we don't have perfect information around what the future will look like around IMD, I don't want that to be a barrier to at least starting some of these really important conversations today. If you have more questions about IMD, which I'm sure many of you do, you know where to reach us. Our contact information is going to be included in the last slide, and we can make sure all of you have that if you want to have some more conversation offline around IMD. But with that being said, let's move on to talking about who's really at the root of our design for today, which is children and youth. So I love this quote because I think this is really what we're up to, right? The people you're designing for are your roadmap to innovative solutions. So in our case, the children and youth that we are designing for are going to provide the roadmap for how we move forward. And we're going to take a human-centered design approach to our conversation today, which under human-centered design, really, it's talking about the intersection of desirability and the human aspects of design, viability, the business aspects, and feasibility, all the various technical elements of an idea. And it's the intersection of those three things where you're going to get the highest, most innovative impact. With every human-centered design approach, however, we always start with desirability, the human piece. And that's where we're starting today, right? We want to ground all of our discussion and ideas around the children and youth in the system and dream big around what they need and the system that they deserve. Knowing that, eventually we have to get to issues of viability and feasibility. So we have to talk about rule changes. We have to talk about rates. We have to talk about all those other things. We're just not going to talk about them today, right? So today, I want you to really focus on the youth and their needs, to have big ideas around that. And then we will take those ideas and then figure out how to make it happen in a sustainable, successful way. And to help us do that, as we move forward in our discussions, we're going to be grounding our discussions and getting to know these 6 youth. We have developed some in-depth case studies to use in our small group discussions today. So you will meet one of these youth in your small group. And we've built out a case study to guide kind of the discussions and ground it again in that human experience. The 6 case studies are representative of youth who are currently in the congregate level of care in Colorado. They are by no means representative of the full spectrum of subpopulations that we serve in our system, but they are examples that we can use to, again, spur innovative ideas and thinking. They represent kind of the higher end of the continuum in terms of complexity of needs, and that is, again, intentional. Right? The thought is that if we design solutions around that higher level of need, that by default, we are creating solutions for the majority of children and youth in our system. And if we design for that higher end level of need, it will hopefully spur us to think of things that we might not otherwise have thought of. And so we were trying to be very intentional in the creation of these use cases. Again, they're not representative of all youth. but they will hopefully help get us to where we need to get to today. The design challenge is really, again, how do we meet the comprehensive needs of these youth? And you'll see in your groups, we've kind of split the group in half, right? 3 of the 6 youth are going to be in the QRTP level of care. So those groups are going to be talking about what does the QRTP level of care look like, including discharge planning. And the other half of you are going to be talking about how could we serve these youth who have a high level of need in community-based alternatives to residential treatment. So again, straddling kind of those 2 sides of the issue in our discussion. So again, that's what's to come in your discussion groups later on today. Before we break you out into small groups to read your use cases and respond, wanted to take a little bit of time to provide some really great examples and hear from some of your colleagues in the field who are engaging in this work. And the purpose here is not to say these are the answers and this is what we want to create, but rather for you to listen to these examples and experiences to help spur more thinking, more ideas, and more questions. Okay, so for today we have 3 on our panel. First is Molly Ramirez from Shiloh House, and she's going to be talking from the provider perspective about, again, really over the years, Shiloh House building out a continuum of services and programs in response to the needs of children and youth, as well as a whole collection of different partners. Tad Barker from Denver County is going to provide a county perspective on some of this, because again, we're not just asking providers to change. All of us need to change. And so he's going to be talking about some of the culture shift around staffing of youth and the use of congregate care that's been going on in Denver. And then finally, we have Andrew Gabor, who's going to give us the behavioral health lens, specifically around the CANS and the independent assessor. And like I mentioned earlier, kind of busting a few myths about truly what does that independent assessment represent and what does it not. So we have that in our minds too as we go into the small group. And so Molly, if you are ready, Molly Ramirez, if you are ready, I can turn it over to you to talk a little bit about Shiloh House and how you've worked to build out a continuum of care.
Yes, great. Thank you so much. So if we want to just go ahead and go to the next slide. I'm Molly Ramirez. I'm the Deputy CEO at Shiloh House. And I just wanted to take a moment today to talk about kind of the idea of collaboration as well as just the continuum of care and what we believe in at Shiloh and what we've kind of have done over the last several years. Aligned with Families First, I mean, we definitely believe in the idea of prevention, right? Of being able to provide those services to the child and the family in the home in hopes that we can provide the structure, the skills, whatever is necessary to keep that child in the home and ideally prevent any type of out-of-home placement or DHS involvement or further DHS involvement. And so we've really created these programs on the left and the ones that kind of go across the screen as a preventative measure of being able to work with the child and the family and really kind of circle around them in their home on a preventative measure. We believe strongly in the intervention. We recognize that, especially as RCCF with a lot of residential programs, we're seeing a higher acuity of youth that are being sent to our residential programs and really seeing that there are a lot of youth with some really high needs and high trauma and struggles, and recognizing that there still needs to be a place for them and there still needs to be a safe place and a safe spot for them to lay their heads. And so recognizing that we have our residential and we'll be pursuing QRTP and really looking at what opportunities lay in front of us. But if a youth does need to be in that residential setting or that out-of-home placement, what can we do that the residential idea doesn't need to just stand alone? And so one thing that we've been very intentional about is providing our other services around that child and that family while they're in the residential setting. So whether that be with our Beyond the Walls program and connecting them into independent living and getting them a mentor, or connecting them with after school programming that they could be part of when they do discharge, and helping them kind of gain those pro-social activities and interests while they're in the residential setting. And to not forget about the family, right? That wherever they're discharging to, how do we support that placement? And so we've really built our programs on that kind of intervention piece as well. And then we have that aftercare side, which I think we can all agree on is vital. And we started developing our aftercare programs several years ago, really seeing that we were doing good work with our kids that were in residential and that they really were making strides. However, once they left, there were some gaps in services, whether that was due to funding, whether that was due to just the service not existing. And so we started to develop these programs on that aftercare side as well. And again, creating a program or creating programs that can truly circle around the child and the foster family, the bio family, whoever that unit is that is supporting that child and family, whoever is involved, how can we get the right services to them? And really creating these programs to extend this continuum of care so that we can give the right service to the right family at the right time. And so kind of extending it and developing different programs that will meet that need. One of the ways that we have really been able to build our continuum of care is through collaboration. And so we can go to the next slide. I'll give 2 examples of some collaboration that we've been really joyful to be part of. And one of those being our Family Resource Pavilion. And so I believe, is there a slide with our list of partners on this one on the next slide? Sorry. Maybe not, no. So we have a list of partners that helped create the Family Resource Pavilion. And this really was an idea of bringing together all the different entities. Arapahoe and Douglas Human Services were a huge part in this project, as well as Synergy and the Juvenile Assessment Center and Diversion and a lot of other entities, where we came under one building to create this one-stop shop for families. And so that families wouldn't need to be sent all over the county, the state to receive the services that they need, but they can come to one location and truly be met with what they need and truly assess with what they need and be able to receive that all in one location. And so that was a collaboration the Family Resource Pavilion opened in 2016, but it took many years prior to that with a lot of planning to be able to get to that point to create that building. And one of the components of that building is respite and assessment. And I think that's vital, especially as we've been hearing from foster families and as we're expanding foster families, is that need for that respite setting, right? For them to be able to take a break, and even bio families to be able to have that breather and take a second to assess what needs to be done, what's going on, how do we serve you with the right services and give that break that's needed. And so we have a 12-bed respite program out of the Family Resource Pavilion where children can come, families can take a break, but we also are assessing what needs to happen once they leave, right? So not just sending that child back into the same home with nothing, with no services, but really working with the family and working with the child of, okay, what do we need to wrap around you to be able to provide some stability and be able to provide all of the skills and things that you need. And so our program has been really successful over the last several years. We'll be expanding this respite and assessment component and idea because we're really seeing that that's a need in our community. And again, as foster families are starting to really, describe that they need that service and they need that break, and with this respite idea and this ability to stabilize, it can really help prevent disruption of placement. It can really help prevent out-of-home placement, because if we're able to get in there and get there before the crisis blows up, then we can truly help that child and the family the way they deserve to be helped. And so that's one of our bigger collaborations that has taken a lot of different entities to make successful, but it continues to be successful and continues to really serve families the way that they need to be served. And so we can go to the next slide and we'll discuss another, so another collaboration that we've had. Here we go. Another collaboration that we've had the opportunity to be part of is a quarantine unit that was created. As we know, the pandemic obviously hit our country and our state pretty hard. And so at the inception of the pandemic, we were approached by several of the partners that are listed on this list, out of this fear that youth who have had possible exposure to COVID-19 wouldn't be accepted into some of their placements because of the fear that they had the virus. And so we needed a place for these youth to be able to go. And so we created, with our partners and with collaboration, in a very quick amount of time, we were able to create these quarantine units where the youth was able to come, get their testing, wait for the results, and upon the negative results, be able to discharge to their placement option. And this was a huge feat. I think at the point of the first conversation to the point of the first admission of our youth, it was about a 3 to 4 week period. And I wouldn't exactly suggest doing a new program in collaboration that quickly, but I think it definitely demonstrates what can be done when you bring all the right people around the same table, and recognizing that each of our agencies don't need to do it on our own, that if we really partner with other agencies that can support us and can do other aspects of it, that's where where creativity can come from and how it can be a really beautiful thing. And so since that program is open, we've been able to serve about 100 youth in the quarantine units. And our program is still running. Hopefully it won't need to be running for much longer. But that's 100 youth that wouldn't have necessarily had a place to go, or would have potentially been placed in the wrong spot just because there wasn't a spot for them. And so we were able to create these quarantine units. It was under our RCCF license, and we were able to work with the state and licensing and really just make that program fit what those youth needed at the time. And so that's a really another example of the collaboration and what can be done. And I think overall, we believe in collaboration, and we truly believe in the continuum of care, and not necessarily taking anything out of the continuum of care, but how can each of us play our role and play our part in adding to that continuum of care. And rather than drawing a line in the sand of this is what I do, this is what they do, but actually how can we all kind of be in the sandbox together? And if we can truly kind of extend this continuum of care, we can truly help families and have the right service for the right family at the right time. And so that's kind of what we believe in and what we've been in participating in. So that's a lot, but thank you for the time to speak.
Sorry, I was trying to unmute myself. Thank you so much, Molly. Just beautiful examples, I think, of everything we're trying to embody in this discussion, right? Collaboration, responsiveness, diversifying kind of services and levels of care throughout the continuum. So thank you so much for providing those examples. And sorry for the glitch in the slides. You guys have literally so many partnerships and collaborations that they can't all fit in the slides. So thank you so much, Molly, for sharing. So now, and do we have Chad Barker on the call from Denver?
Yes, I'm here.
All right, Chad. So we're going to hear from Chad now from Denver County to kind of give a county perspective of some of this and some of the culture shifts and changes in approach and thinking that Denver's gone through over the years in response to something. So take it away, Chad.
Thank you. So my presentation is not going to be as detailed as Molly's. I can't really follow that, but in thinking about what we've been through over the years as far as our congregate care, the example that comes to mind for me is when El Pueblo, when Excelsior, and when the Denver Family Crisis Center all shut their doors. We were left in a situation of, okay, what are we going to do with all of these kids who are at this residential level of care that we now have very little time to get them moved somewhere else? What we found is that in the example of the Denver Family Crisis Center, about half of those kids were able to go home and go home with services. And when I say home, I mean either their bio parents' home or to kinship homes. And we just put services in, and it worked out really well. Another thing that was curious about that situation was all it took was for it to be said, this facility is closing down, and all of the barriers all of a sudden started melting away. And we were able to send kids home. We were able to step kids down into foster homes. And there was a small handful of kids that we needed to move from one facility to another residential facility, but it was very small. And again, it was very significant and standing out in my mind that about half of those kids actually went home. You know, I find that a lot of workers, therapists, GALs, the court, all very well intended and wanting to do the right thing. But again, the barriers just kind of melted away, and that culture shift just clicked of different thinking. So what we did in that situation is I only assigned one of our staff people to close these facilities down, and they were able to do it very smoothly, very efficiently, and they made the deadline to get the kids out. So it didn't take a lot of manpower from the placement navigation staff in order to accomplish this. We definitely mapped out the kids who were in the facilities, who their caseworkers were, who their GALs were, why they were initially placed in those levels of care. And we kind of broke that down and started picking the low-hanging fruit off first, as far as, you know, who is ready for discharge at this point in time. And those are the ones that we were able to quickly get out. That resulted in us keeping a whiteboard out in front of our division director's office in our administration area for a constant reminder to all staff of, you know, this is what we've got going on, and look at the number of kids. And we had regular stand-up meetings every day in front of this board to see where we're at, what are our progress, what are the barriers that are standing in the way of us being able to step down or send home. And it resulted in also meetings with caseworkers, therapists, GALs, to pull them together and say, okay, we are forced into a situation right now. This resource is going away. How can we be more creative in how we're thinking about dealing with this child and getting them the help that they need, but trying to get them back into a more family-like setting. And again, it was very, it was smooth, a lot smoother than I thought. There were a lot of tears, a lot of worry that, you know, we're losing this resource, we're not going to be able to do it. How are we going to go on in the future? And it was very clear after it was shut down. I was like, hey, we really didn't need this place. There were other avenues that we could explore going forward in order to not have as many kids in higher levels of care. Currently, Denver County is now doing group supervisions when we're really just stuck on, you know, what are we going to do with these kids? And it results in a lot of conversation and banding about different ideas and checking into different avenues. And it helps those workers kind of think through it and slow down because they're too close to that situation. We found a lot of very creative ideas and avenues in order to find alternative placements to lower levels of care. And our numbers for congregate care have gone down throughout the years since the Crisis Center and El Pueblo and Excelsior all closed. So I think that it's been effective, but again, I think we need to have that culture shift in knowing that, hey, we can do it without as many residential facilities as we had on our plate at one time. I think that it was pretty simple. I can't go on enough about how simple it really was, and how at the end of the day, despite everyone's fears that we're just not going to be able to do this, we're just fine, and we're moving on. So I have hope that with the changes with Families First and adding QRTPs with IMD, that it's just going to be just a little bit more magnified, but we're going to be okay. We're going to find new ways of working with kids. We're going to find new ways of leaving them at home and not placing them in higher levels of care because it makes us feel better, or, you know, they just need to stay another month and then we can do it. We've got it and we can do it. And it's been shown on a smaller scale throughout the years with the closing of these facilities. That's what I got.
Thank you so much, Chad. I think we all needed to hear that message. I know I need to hear it daily of the we can do it. And there is for sure hope and a pathway to navigate all the change, and we can do it, and we have to do it on behalf of children and youth. So thank you so much, Chad, for that insight and for those examples. And then last but not least, Andrew Gabor, I see you on the call. Andrew is with the Office of Behavioral Health and has been very much focused on working with us around Family First and implementation of the independent assessor process and utilizing the CANs. But I wanted him to not give us a training on those pieces, but rather talk a little bit about what they actually mean and what they don't mean. So that when we go into our small group discussions, we're not putting up false barriers around, well, if the independent assessor says this, then we have to do this, right? So Andrew, I'll turn it over to you to kind of give us your perspective on these things.
Sure, absolutely. Well, thank you. And hi, everybody. So really, I want to start off by kind of that first little subtitle of what is the CANs. And we're not really going to be talking about the CANs because there's been a misnomer and a misperception of the Family First Independent Assessment as the CANs or the CANs assessment. The CANs is a tool that an independent assessor will be using when evaluating any child or youth who's going into a qualified residential treatment program. Just like if you go into a mental health center, you might get a trauma screen or a depression screen or any number of tools. Division of Youth Services uses a number of different assessment tools for any youth or child entering their system. The CANs is just another tool that we will be using to help build consensus primarily, and then to help guide the actual assessment that will be happening. And so I wanted to kind of get that out there first and foremost. So a lot of people like stick into the CANs and like, okay, well, what's the CANs going to say? Well, it's much, much, much more than that. Because really what it is, it's an independent assessment. And that's a federal requirement. And it's really a full psychosocial assessment. It's very similar to like an intake you would get if you went to a mental health clinic or a mental health center or a residential provider today. We do have a few more tools and it will be much more robust than a standard intake would be. So one of those differences is that it will be completed by a licensed professional. So that is like a licensed professional counselor, an LCSW, LAC, and I can go through all the different acronyms of what all these are, but they're licensed. So they all have at least a master's degree, or they're a psychologist or psychiatrist if they so choose to participate. But they cannot be a recipient of or work for a 4E recipient. So that means they cannot work for the county and they cannot work for the QRTP itself. Okay. They cannot have any kind of liability of not being completely independent because their employer gets funding through 4E. Okay. One other thing is that this only applies to children and youth who are in the custody of a county or the Division of Youth Services. This does not apply, this independent assessment does not apply to Medicaid youth where like let's say a Ray wants to place a child in a QRTP, or a private insurance company, or another program like the Children Youth Mental Health Treatment Act. They will not be using these independent assessors. These are really just for DYS and child welfare kids, okay, and youth. But so this licensed professional will go out and do a face-to-face evaluation on all these children and youth. They will also be meeting with a family, if at all possible, that will be in person, but it might be through telehealth. And then they are required to reach out to all of the collateral that are out there as well as they possibly can. So that includes the schools, guardians ad litem, religious leaders, siblings. I think we had seen the list somewhere, not on this one in particular, but caseworkers, obviously, any previous or current providers, hospitals, if they were recently in a hospital, Division of Youth Services, really trying to get the fullest picture of what's going on for this child, youth, and their family, as well as we possibly can in a very short time frame. And they'll review all the different documentations as well. And the counties will take the lead in making sure that these evaluators get those documents in some kind of a timely manner. And then once they write up their assessment and have as much information that they possibly can, there'll be a family meeting. And that will be obviously with the family, preferably with the youth for sure, and with any other individuals that are required to be there. And in that meeting, the idea is to get consensus. And that if there's not consensus, then how do we try to achieve that? And if that doesn't happen, then that needs to be documented for the courts to review as well. Okay. So the assessment will identify the areas of need and the areas of strengths for the child, youth, and their family. Okay. I talked about the permanency meeting that will happen, and then they will recommend a level of care based off the clinical needs. So one thing that's different between the today residential childcare facilities, the RCCFs, and the new QRTPs, the Qualified Resident Treatment Programs, is that QRTPs are for clinical behavioral health interventions, so treatment. It's not for placement. We're not placing children in QRTPs. We are identifying that children need treatment and they will receive treatment in these facilities. And that's a pretty big distinction between the two different levels of care. And this independent assessor, this gatekeeper, will be making a recommendation, typically to the courts, about what level of care would best meet this child and their family's needs. If their clinical needs do or could be better served in a lower level of care, then they should be served in a lower level of care. They will also outline some short and long-term goals for that child and youth, and that is a federal mandate as well. So keep that in mind. Let me think, I'm trying to think of other things. I mean, this is like an hour-long presentation that we can really get into the weeds on. There's lots and lots of questions. I'm sure I can see the little chat box move in, but just want to let you know that also the independent assessor, they are the gatekeeper, but they will not continue to do the ongoing placement or treatment evaluations once the child is in a QRTP. That will go to other departments. The facility will also continue to do the CANs on a consistent basis that's outlined in proposed rule as well. So the independent assessor, they go in, they do their evaluation. It's within 14 days. It's very quick, and they're done. So that's the independent assessment in a nutshell.
Great. Thank you so much, Andrew. And I know there is so much more to dig into. And Andrew and a whole bunch of folks are working on a whole series of trainings for all the involved stakeholders in better understanding the CANs, the process, and what it means. And so there is much more information and trainings that are going to happen for sure around these things. But wanted to make sure we all had that base level of knowledge around this, again, as we go into our discussion, because I think sometimes from what I've heard, even myself sometimes kind of give different weight to this independent assessment than is meant to. And there's still lots of discussion that happens around the needs of a child or youth and where the appropriate placement and services are. So thank you very much, Andrew, for that quick overview. And so now with that wraps up our panel. And I hope you, hearing these different perspectives and these different examples, have helped raise some different questions or ideas in your head as well. And so now we are going to be transitioning into the second half of today's meeting, which is really about, let's get some ideas out there and start talking about design and what we truly want the future to look like in more tangible terms. So another quote to keep in mind as we move forward: human-centered designers are persistently focused on what could be, not the countless obstacles that may get in the way. Constraints are inevitable, and often they push designers towards unexpected solutions. So I urge you, as we move forward into the small discussions, to not get stuck, right? Not get stuck in all those pieces that we know we need to address to be successful and sustainable in some of these things. Stay in that place of dreaming big and big ideas and what we want for youth. So what we're going to do, if the technology cooperates, is we're going to break you all randomly into small discussion groups that will have a facilitator in each room. And hopefully it'll be a nice, diverse group of different perspectives at the table is what we're hoping for. So take a minute to introduce yourselves to each other once you're in your room. And then, like we mentioned, each of you are going to be assigned, or each group is going to be assigned a use case. So one of those 6 use cases. So you're going to take some time to read through your use case. And your child or youth will either be placed in a QRTP in the particular scenario, or with the goal of receiving services in a community-based alternative to residential care. So be looking out for that distinction in your case. And then really what we want you to do, you're going to be using Jamboards. And if you haven't used a Jamboard yet, don't worry, they're very user-friendly. If you've never used it, we can give you a very quick tutorial and hopefully you'll be able to dig right in. But basically, we're going to give you a virtual whiteboard and pretend that we're all physically together with a bunch of sticky notes and markers and can put our ideas together. So you're going to do some brainstorming, again, focusing on creativity, not just feasibility, right? And then you're going to start identifying themes that are emerging from your group discussion and choose your top 3 ideas. What are your big ideas, your best ideas that you want to see the state help build out over the coming months, okay? Because we really do want to turn this into action and next steps and not just have it be an interesting conversation for today. So again, once you get in your groups and be a little patient, it's going to take us a minute to get everyone broken out. Introduce yourselves, read through your case study. This is what a Jamboard is going to look like. So you're going to, up at the top, scroll through different pages of the Jamboard. So you're going to have to scroll over a couple pages to read the entire use case. And then you're going to use these sticky notes on your Jamboard when you start engaging in your brainstorming to put your various ideas on. And then you're going to play around together, right? Mix and match things, circle things, cross things out, star things. And your ultimate goal is leave us with your 3 best ideas as fully fledged as you can get them, right? So that we can figure out then how to run with them and turn them into reality. Okay, so that's your challenge. And before we let you go into breakout sessions, let me check with some of my colleagues, Angelina or Maria, if there's anything I missed logistics-wise that you want to cover before we break out.
No, I think we're good, but I appreciate you saying and reminding folks, give us a minute or 2 to get everyone into the breakout groups. Have a little patience. It takes time to coordinate 115 people and make sure that you all have hopefully a facilitator in your group. Also, I see, Krista, you raised your hand. We're not really taking questions because we're trying to break folks into groups. If you want to hang back for a minute, there will be some of us who stay in the main room and you can ask your question at that time, or you're welcome to put it in the chat too.
And then Angelina, the last thing I'll say is last 5 minutes, we'll get everybody back together for a quick closeout and then that'll be it. So good luck.